following seminar we will talk about suturing and suture techniques in periodontal and implant surgery. For sure this is a topic that is interesting and important for everybody who is practicing this kind of surgery. Suturing does not only mean to approximate two flap edges with each other. Suturing also means to stabilize a wound, or in other words, to maintain the stability of the blood clot underneath the wound or in the wound, which happens in all kinds of situations after surgery. Techniques and the suture materials. There is something unique in periodontal and peri-implant surgery. It is the fact that we try to restore or replace soft tissues on avascular non-shedding surfaces. On such kind of surfaces, the blood clot adherence is not the same as on a connective tissue wound bed. On the right side, you see the suturing after a recession coverage. Several sutures that firmly fix the flap on the wound bed. If there is mobility in the wound area, the blood clot will disrupt, and this will for sure influence the healing. The blood clot underneath the flap is the most elastic polymer the human body can perform. But not all of the blood clots are the same. Did you know that different patients have different clots with different behaviors? So for example, the blood clot of obese patients or of diabetic patients produce fibrin fibers that are thicker than in other circumstances. So a fibrin clot that is consisting of thin fibers with many branch points is more elastic than a fibrin clot that consists of thick fibers. For comparison, I show you this slide on the right. You see the elasticity in the graph, or the difference between a collagen fiber and a fibrin fiber. You can see that the fibrin fiber is elastic to a much higher amount of force. And then when you extend the fiber beyond a certain extent, the molecule will be irreversibly damaged. That means that we as clinicians can influence the force that we bring to the clot or to the fibrin fiber. That means that when we suture a flap with some tension, we will damage irreversibly the clot and influence the healing. So by just choosing thinner suture diameters, we can influence the force that we bring to the clot. We will talk about this later on. There are several studies that investigated the clinical behavior of the clot. For example, a clot under tension resorbs more slower than a clot that is not under tension. On one side, the clot has to be an open structure to allow access to the fibroblasts. On the other hand, it must be a firm structure to resist towards the forces that are applied. So again, as clinicians, we influence the resorption time of the clot by the forces brought to the wound. Another important fact is the ingrowth of capillaries. It has been shown that the clot under tension is slower revascularized than a clot without tension. Cells from the endothelium, from the surrounding capillaries, will ingrow, but if the clot is under tension, lumen formation does not take place. In the next section, we will talk about suture material, that means the needle and the suture strand. So these two components are important for the suture. Regarding the needle, usually in periodontal surgery, we are working with 3/8 curvature needles. These allow a right-angled entry and a right-angled exit in the tissues. When we come too close to teeth and we suture releasing incisions, we have to choose a needle form that has more curvature, that means a half circle curvature, or an asymptotically curved needle which changes the curvature in each segment of the bow. An important aspect of the needle is the tip. Usually we are dealing with very coarse tissues. That's why the needle tips have to be very sharp. It depends on the tissues. If, for example, we have to suture the Schneiderian membrane in a sinus augmentation, the needle tip has to be rounded, otherwise the tearing will open again or more if we have a very sharp needle. When we are suturing, we have to grasp the needle in the middle part, never at the tip, in order not to damage the tip, or not in the lock where the suture strand is attached to the needle. In some needles, the strand is attached by clamping the needle, and in others, there is a laser drilled hole where the suture strand is adhesively fixed. On these slides, you see in high magnification the damage to the tissues, which depends not only on the size or the needle tip, but also mainly on the lock of the needle. A laser drilled hole damages less than a clamping attachment of the needle and the strand. But it's not only the configuration and the length of the needle, it's also the material, namely the steel, which will influence the behavior of the needle. There are steels that allow more flexibility of the needle. That means when you touch the needle, it will less bend compared to other needles. When we talk about suture strand, there are three different main modalities. We have the monofilament sutures, the polyfilament ones, and the pseudo-monofilament ones. Pseudo-monofilament ones means polyfilament ones that have a coating and a smoother outer surface. Generally, the polyfilament ones show more sawing effects when they are pulled through the tissues. That's why we prefer the monofilament ones. Here you see in high magnification the differences, and you can easily imagine that in aqueous solution and bacterial-loaded environments that the adherence of bacteria will be more pronounced in polyfilament ones than in monofilament ones. Gore-Tex or polytetrafluoroethylene is a special material with very convenient handling properties. But as the material is stretched, the surface is bigger and the adherence of the bacteria will be more pronounced than on smooth monofilament ones. Friends, in the following seminar we will talk about suturing and suture techniques in periodontal and implant surgery. One of the problems in suturing is the trauma. Suturing always is a trauma. So in the first 24 hours, the mechanical trauma will be the main trauma, while in the following wound healing period, trauma by bacteria will increase. Bacteria adhere to all non-shedding surfaces. That's why plaque control during the healing period is of utmost importance. Today we have suture materials that are coated with, for example, triclosan that inhibits the adherence of the bacteria in the wound healing period. It depends on how long the suture will stay in your oral cavity. The longer they stay, the deeper the bacteria will penetrate along the stitch canal and along the suture strand. That's why I prefer the sutures to be removed at the earliest time point possible. I think there is no one general time point ideal to remove the sutures. It depends on the surgery and on the stability of the wound when we remove the sutures. On the right side you see such inhibition zone by triclosan on this suture strand. Today we not only have the resorbable ones that are coated with these inhibition solutions, but also the non-resorbable ones. We choose suture diameters in periodontal and peri-implant surgery very often 3-0, 4-0 or maybe 5-0 sutures are chosen. Surgeons are choosing suture material based on tradition, habits or whatever, or the price of the material, but very rarely depending on the biological properties of the sutures. Does it make sense to choose a suture with a diameter 3-0 or 4-0 that it can be loaded up to 10 or even more kilograms when you suture such a very little tiny papilla? You can see in this graph that the breaking strength depends a lot on the diameter of the sutures. In a recent experiment, we were influencing the diameter of the sutures to the breaking strength and, as we have already seen, to the forces that are brought to the clot. We were harvesting soft tissue grafts in picture mucosa, and we were trimming the grafts to a defined width and length. Then we were attaching these grafts in an apparatus of a Swiss textile company with different diameters of sutures, 3-0, 5-0, 6-0 and 7-0. While in the 5 and 6-0 we also tried with different needle configurations. The measurement arm was moving with a constant speed until something happened. So you can see that in the thicker sutures, the tissue breakage was the main event, while in the thinner sutures, almost exclusively, the suture breakage was the main event. That means that by just choosing a thinner suture diameter, we can define the force that is brought to the tissues. So this could be a control of the tension that is brought to the wound margin and at the end to the blood clot underneath. Based on these experiments, I recommend in periodontal and peri-implant surgery to choose suture diameters in a range of 6-0, 7-0 and maybe 8-0. On this slide you see a suture papilla, and you can imagine that a tissue with a diameter within millimeters should not be sutured with suture diameters of 3-0 and 4-0. Otherwise the mechanical trauma will be too high, and additionally, as we already have seen, the tension of a suture of 3/0 and 4/0 cannot be controlled by the surgeon. In the following section we will talk about suture techniques. So the basic technique is an interrupted suture. Handle the tissues with care. That means when you grasp the tissues, use an anatomical forceps. Try not to squeeze the tissues. Support the tissues with your anatomical forceps and slowly pull the threads through the tissues to avoid the sewing effect. If you do an interrupted suture, try to grasp the whole tissue thickness. So you enter right-angled and you exit right-angled. Try to keep the bite size, that means the distance from the wound margins, the same on one side than the other side. You can stick in the needle in the neighborhood for a fluently work. You can do that even in the sites where there is no anesthesia, because the epithelial, the thickness is thick enough to stick in the needle and the patient will not experience pain. This guarantees a fluently work as you can grasp the needle immediately in the right direction that you go on with suturing. When you tighten the knot, do it visually guided and not with your tactility. The reason is when you are using very thin suture diameter, you cannot have a tactile feedback. That means when you pull the thread, it will break without any resistance. Something else that is important is that what I already mentioned, why you choose or tighten the knots or suture with two instruments. The rotating movement for the right-handed persons from 2 o'clock to 7 o'clock is the most precise movement the human body can perform. So when you use instruments without rounded handles, you cannot guide the movements like this, but the movements are guided with the muscles of your forearms, which are more coarse than the muscles of your fingers. Beyond these interrupted sutures, we have 4 basic techniques of mattress sutures. We have inverting and everting mattresses and horizontal and vertical ones. Between these, you have many forms in between. These are just the basic techniques. Here you see again, as an example, the horizontal everting mattress that can be used for closure of a crestal incision, especially when you have some biomaterials underneath and a primary closure must be guaranteed. Again, you pull the thread very slowly through the tissues and then you go to the opposite margin. It is important here that you initially pull the thread to a short end, otherwise you will have more sewing effect in your tissues when you only pull it at the end. You right angle penetrate again and then you suture the thread and tighten the knot. As you can see here, it depends on the suture material, how many times you turn the thread around the needle holder, but usually 2 times with a double sling is enough to secure the knot and it will not open anymore. I hope I could give you some valuable information about suturing and suture techniques. Thank you for your attendance.